live.
You're live. You are.
All right, we are live. All right, so I thought I'd do a little bit of a recap of what we talked about, since there's kind of a lot of moving parts to it. In terms of vasopressors from, I guess it's been a month already, last month. And just some of the general principles. So I wanted to start with, you had a little bit of a preview there with our vasopressors, where they act and in what receptors they act. But this is just a very simple diagram about where our receptors are and what they do. And I'm going to tie it to this chart real quickly. So you've got your beta 1 receptors on your heart. That's going to cause squeeze. Think squeeze or inotropy, heart squeeze and heart rate. Okay? And then you've got your arteries, which have alpha 1, V1, and V2 receptors. Think vasoconstriction, phenylephrine, vasopressin, midodrine, and these to a certain extent causing vasoconstriction of the arteries. And that's your systemic vascular resistance, causing resistance in the periphery there. And then preload, which is filling the heart, alpha 1, V1, V2 as well. So the same thing, causing constriction on the venoconstriction on the venous side of things, causing venous return to the heart. The more that comes out to the heart, the more that gets pumped out, increase your cardiac output. So all of these things we're using to try to maintain this, correct? Your MAP, your mean arterial pressure, which from that we saw is equal to cardiac output, which can be further be broken down into heart rate. So we're going to have more cardiac output the faster we squeeze. And we're going to have more cardiac output the more stroke volume we squeeze out. So these inotropes here that hit beta 1 and help us squeeze. And then stroke volume can further be broken down into these two things. So the squeeze, contractility, how much we're going to inject out of the heart. And then again, preload, if we bring more back to the heart, it dilates the heart, it causes it to squeeze down harder to a certain extent. So we can tag our different inotropes, inopressors, strict vasopressors onto this chart. And then also over here in the system of vascular resistance. So if we're to do that real quick, we'll say norepi's going to do heart rate because it's alpha, beta 1. Phenylephrine, where is that going to act if we're just going to go down this chart? SVR. Yeah, SVR. Phenylephrine. It's also going to work here. Norepi is also going to work here. Norepi is also going to work here because it's got that alpha. Vasopressin. Where's that going to work? It's going to work here. It's going to increase our vaso is going to work here and here. What else is going to increase our heart rate? So we got norepi, yep. We got epi, dopa, yep. Debut. And then contractility is going to be all of these as well, to a certain extent. Norepi, epi, dopa, debut, contraction. Milrinone's on there. Okay. I don't need to put like all these down, but does that make sense? Tying it back to this diagram and what we're accomplishing, and it always, all of critical care comes back to physiology, what we're trying to do, and how are we manipulating this equation to get our goal based off the patient. So kind of a quick overview. You guys got more in depth of that last time, but now what I want to do is talk about sort of progression of these things in septic shock. So septic shock is a distributive shock where sort of the tank, the vessels are kind of wide open, okay? So we need to work on this component of things for sure. But you can also get, in different forms of septic shock, you can also start to get heart dysfunction and the heart doesn't work as well. But those things aside, if we're trying to solve typically this type of an issue, with the systemic vascular resistance, what is our first line vasopressor? Norepi, okay. Right, because we said it's kind of like, it's like the do everything. You get your heart rate, it improves preload, does a little contractility, it definitely increases your SVR, so it's doing like everything. So it's like the all-in-one vasopressor, which is nice. So there shouldn't be any if it's unclear what type of shock they have, norepinephrine is probably not a bad choice, and certainly is not a bad choice for septic shock given its characteristics. Okay, so norepi does have, like anything we do in the ICU, has some side effects. So if you're vasoconstricting, can you think of some areas of the body that would be pretty sensitive to vasoconstriction potentially? Extremities, yep. So you can get digital ischemia, really high dose vasopressors for a long time. You can get death of digital ischemia, death of your limbs, death of fingertips turn black. Has anybody ever seen that? Yeah, so you can get that. Where else can that happen in the body?
The gut.
It can happen in the gut, exactly. So you can get gut ischemia. It's bad when the gut dies. You can get reduced renal perfusion. So there's always a trade-off. So does anybody know about how high we want to typically go? There's no ceiling on norepi, but to stay safe for a longer period of time, do you know about where we want to transition to our second vasopressor?
12.
Yeah, around like 15. Because of those side effects, you typically want to go to what's your second? Okay. So we're going to add something that works on a different receptor. We're going to add that into the mix, vasopressin, okay, at about 15 mics per minute. So there was this VAST trial done in 2008, and it looked at people in septic shock on norepinephrine. And they took a group and transitioned them at a range of norepinephrine doses, but 5 micrograms, when they transitioned and added vasopressin, there was a trend towards improved mortality. However, at 14 micrograms per minute, around 15, there was a 10% reduction in mortality in those patients at 30 days and 90 days when you added vasopressin earlier, rather than just going up on norepinephrine. For all of those, probably all those side effects I just mentioned, when you go too high on norepinephrine. So that's why we add vasopressin typically around that range, or we should. So I said first, second, 2.5-ish, I put steroids there, okay? So the newest guidelines and evidence have shown us that once you're starting to add vasopressin and someone's, heading in that direction of worsening shock, we should think about adding steroids, okay? And there's a bunch of literature from like the early 2000s guiding us on, do we do hydrocortisone, do we not? It's flipped back and forth in terms of, is there a mortality benefit, is there not? But now, there was a meta-analysis in 2023 looked at hydrocortisone plus fludrocortisone versus hydrocortisone alone in septic shock. And in-hospital death or discharge to hospice was reduced by an absolute risk reduction of 8%. So it does appear to have a signal to improve those parameters. And I would say meaningful outcomes that we care about. So how does hydrocortisone work? How does fludrocortisone work? So in sepsis, when you have this huge catecholamine surge, this huge stress to the body, there's this thought that we develop sort of this relative adrenal insufficiency. So our adrenal glands create steroids. We need steroids to maintain our blood pressure, our sodium levels. They do all sorts of other things in our body. They help our receptors react to vasopressors and natural catecholamines. They're kind of like the milieu of what keeps things together and keeps things functioning. So if we have adrenal insufficiency or relative adrenal insufficiency, steroids should help that and improve our shock state. And they should help improve the receptors and the expression of those receptors on our different parts of our body so these things work. Does that make sense? So it's kind of like an augment, in a way, steroids. So that's why we think about adding these. Now, caveat, sometimes I'll look at them and say, oh, well, they just kind of like need a little more volume. I think we're like, you know, oh, they got a UTI, we got them on the right antibiotics, we're cresting the curve, and like, do I need to hit them with 7 days of steroids? Probably not. But if they're not going in the right direction, then I think this is certainly, and you're escalating your doses of vasopressors, I think this is certainly becoming more in vogue in terms of what we should be doing. And not just hydrocortisone, but probably hydrocortisone, it's 50 Q6 typically, plus fludrocortisone down the hatch, or the OG-NG2, 50, I believe it's 50 milligrams a day. So, you'd probably be seeing me do more of that for our really sick patients on escalating doses of pressors with septic shock. Third line, what,
Depending on other things, epi versus
yeah. Yeah, I like that. So depending on other things, or but typically, yeah, epi, phenylephrine. Debut, milrinone, and you said like depending on other things. So like if I look at that echo and I really see poor squeeze, epi's going to help me out there, but it's also going to make you probably more tachycardic. You get more tachyarrhythmias from it. Dobutamine a little bit less so, and it's a little bit more of a pure inotrope in terms of making like the heart squeeze and pump. As is milrinone, it's more of a pure inotrope. So it kind of depends on your scenario. Do you feel like you're purely septic shock, or do you feel like you're septic and, oh, maybe you have a septic, you can get what we call septic cardiomyopathy. So you're so sick that now the heart starts to not work as well. So maybe you need to add those things on. So that's where I would say like your third line is, could be any of these depending on your scenario and what you're looking at. Questions?
Sir, what are some good MAP goals? Is it always like sticking with 65 in all cases, or do you ever raise the goal to like 75, 80?
Great question. So it does depend. We had just did the ICP lecture, so if we think we have elevated intracranial pressure and we need to perfuse the brain, sometimes we'll raise that MAP goal there. Conversely, there was it's called the 65 trial, where they looked at people with a MAP goal of 65 versus a MAP of 60 in the ICU and outcomes. And actually, hypertensive people did better with a MAP goal of 60. So sometimes you'll see me just say like, they're kind of soft, like, let's just set their MAP goal at 60 to see if we can come off pressors. And if they're still mentating, making urine, and their lactate's not climbing, then 60 is probably fine for them. So it's not just a number, it's a number and is their lactate cleared? Is their lactate staying normalized? Are they making urine? Are they mentating? Are they warm and well perfused? Is their cap refill still good? Are they showing me they're not in shock at 60? That's when I'm going to say 60 is okay. And then if they have intracranial pathology, intracranial hypertension, something where I need to overcome that pressure head that's coming back at me from, while we're trying to figure out other issues like doing hypertonics, getting a neurosurgeon on board, whatever needs to happen up here, you might, to perfuse the brain, raise that goal. So it's all going to be dependent on the patient's scenario, typically. Anything else on just sort of like in septic shock, our thought process in terms of norepinephrine, but it's got, too high of a dose long term, has its side effects. No free lunch in the ICU, so you get to a certain level, then there's a mortality benefit if we add vasopressin earlier. And then if we're continuing to escalate, at this point we should think about starting to add steroids. And then I would say third line, base it off of the patient's shock state scenario. And sometimes this is just a little bit of playing around. Like you add one on, you see what it does to your numbers, you see what it does to all those parameters I just talked about in terms of like, are they perfusing?
I think we had somebody on first line Neo once, and I think a lot of people were confused why that was the case. But I think it was it was very prone to arrhythmias, and that's why we did it. I don't remember exactly. Anybody else remember?
It's probably
that
Partain or
patient?
Moon, right?
Today? Was it you?
I don't know. It may have been. Or like atrial fibrillation with RVR and
Maybe
hypotension. Phenylephrine has a feedback, kind of like parasympathetic, like slow down effect on the heart sometimes. So sometimes it can actually cause like a negative feedback to the heart to slow it down. So that's a form of, if they're hemodynamically unstable with AFib with RVR, which isn't typical, usually they stay somewhat stable. But if they are, so that would be an instance where I would potentially choose phenylephrine. Because you don't want them to go any faster, right? We don't want any of that activity, so so pick something that's purely like that. So I think anything along here, not midodrine, but phenylephrine has the most evidence to say it'll slow you down a little bit sometimes.
So, when there is a heart failure component, how do you then decide of the ones that have more inotropic?
I would typically go with dobutamine, purely more so beta 1. Epinephrine, we typically in shock are looking to clear lactate, and it also stimulates beta 2, which will increase your lactate. So epinephrine can kind of muddy the waters a little bit for me if I'm trying to look towards lactate normalization to say they're not in shock anymore. Because just by starting them on an epinephrine drip, I will likely stimulate beta 2, which increases your lactate. And we can talk about lactate in another lecture, but that's one of the mechanisms that adrenaline increases your increases your lactate. Just like albuterol, continuous nebs will increase your lactate. Okay, so epinephrine doesn't help me there if I'm trying to trend lactates to see how am I doing. And you're more prone to tachyarrhythmias. Sometimes it'll make you go fast, which you don't always like. Milrinone can be good, especially if you also have pulmonary hypertension. It can improve that and improve your squeeze. But again, these other things, you might be limited by vasodilation and hypotension because these are inodilators. They're going to drop your pressure a little bit, increase your squeeze, but cause you to vasodilate. So you always have to weigh where on this diagram, what are you trying to accomplish, and what are your side effects of this diagram, so to speak. So I could do milrinone, but I'm going to have a little bit of leeway on my pressures to know that I'm probably going to drop 10 points or something on my map, or 5 points or so. But I'm going to increase the squeeze.
What are your thoughts about the use of flow track? We don't use it a lot. Do you have a lot of experience with using it? Would you like us to see using it a little more?
I think I prefer to use the ultrasound if I've got good images of the heart because I can get a lot of information. I can shoot their cardiac output with that. I can see what that looks like and base my pressures off of that. So that's typically what I do. I think the flow track is somewhat of a random number generator at times. You have to be in sinus rhythm too. So if you're in atrial fibrillation, it's not going to be accurate. That being said, it gives you a number and it gives you just something to titrate to. So it gives you a cardiac index, and typically you want that for like a dobutamine or an epinephrine or a milrinone. It's like titrate to cardiac index greater than 2.1 or 2.5. We don't do that. We typically say start at whatever, get a lactate, check physical exam findings, and then we increase from there because we don't really have that parameter. Or like a Swan-Ganz catheter to shoot cardiac outputs to show us like where on the spectrum of cardiogenic shock are we. So I think as a trend it's helpful. I don't know that it's not typically been the most accurate. And if you're an AFib with the RVR or atrial fibrillation at all, it's not accurate. You can't really use it. So. Which is a lot of our patients. Okay, I've got like 2 minutes left. Anything else? Anything else pressing? No? Okay. Oh crap. Refractory shock. This guy's like dying or dead. So we've never seen that here, right? Refractory shock, multiple vasopressors. So this is where you need to reevaluate, and this is where I need to reevaluate and get back to the drawing board, okay? So if we're thinking this person's infected, septic shock, if you do not control the source, there doesn't matter what the what vasopressors you're on. You need to control the source. So you're usually going to see me get back to the bedside with the ultrasound. I want to take a look at the heart. Are they developing a cardiogenic shock on top of their septic shock, or a septic-induced cardiomyopathy where the heart's now not squeezing well because they're so sick? There are certain things that we can give them as many vasopressors or inotropes as we want, but it's not going to solve an issue of a pericardial effusion, is it? Or tamponade. That's something that needs to be drained. An empyema or an abscess is that there's no source control. That's something that needs to be drained, okay? The antibiotics aren't getting there. We're not winning the war. Those things, we call that source control. So doing an ultrasound, looking at the heart, scanning the lungs, looking for an abscess. Can't find anything that's obvious. Looking for a pericardial effusion. If you can't find anything that's obvious, CT scanning them, looking for abscess or lack of source control. And then the other one we run into a lot here as well is people come in like so sick, this refractory acidosis. So acidosis is, I mean, you're like literally melting, sort of, so to speak. So like myocardial suppression, so your heart's not pumping well if you're acidotic. All of these receptors aren't working, or these aren't binding because you're acidotic. They need a certain pH to be able to function. Typically greater than like 7.2, okay? So if you're riding at 6.9 constantly, don't think you're gonna be coming off all these pressors. Like you gotta resuscitate them and make some changes to improve that acidosis. So typically it's a metabolic acidosis, so like a low bicarbonate, and we're fighting that. Some of the ways you can fight that initially, just to save yourself a little bit of time while you're trying to figure things out, is like a bicarbonate drip. So trying to push that pH up. There's a bicarb ICU trial that looked at starting bicarb drips with people with like severe acidosis, kidney injury. Showed reduction in mortality, reduction in need for vasopressors, and reduction in need for CRRT. So it kind of staves off CRRT. That's one of those indications to have CRRT done, is you cannot solve the acidosis, and you just need to take over. But again, that acidosis, what's the cause of it? Do they need more fluid? Are they bleeding, and do they need more blood? Do we not have source control and something needs to be drained? Do we not have the right antibiotics and the bugs are still going wild? Do we need to broaden out? So those are all the things we need to think of, I need to think of, in terms of what are we going to do to solve this issue. And to know, and this is what my RTs need to know, is that when we give someone a bicarbonate drip, we are solving one initial problem and creating another, because bicarbonate then buffers and creates CO2. That CO2 needs to be breathed off with a vent, or else it's just going to cause a respiratory acidosis, and then you're not going to solve your acidosis problem. I know this is maybe a little bit above certain levels of learning here, but that's a problem we run into, is we start the bicarb drip, or we just put someone on the vent, pH is 6.9, pH is still 6.9, pH is 6.8. It's like, okay, well, what are we doing to breathe them down with the vent to try to blow off that CO2 if we do start a bicarb drip? Or to just try to meet their low bicarb, their CO2, increasing their respiratory rate, increasing their tidal volume, trying to blow off that CO2 so we can at least get to like 7.2, while we're trying to solve all those other problems that could potentially be causing the acidosis, which I just talked about. So that's kind of the flow of like the patient that's not responding. What are we doing? What are we doing to figure out the problem? And then you've got these nitric oxide scavengers. We talked a little bit about those last time. That's methylene blue and like hydroxycobalamin. So nitric oxide dilates your blood vessels, and so nitric oxide scavengers basically scavenge that ability to dilate. So you don't want that happening while you're trying to vasoconstrict as much as possible. I've actually never used those, but that's an option. I've seen it used a couple times elsewhere, but that is kind of the progression of septic shock and how we should think about it. That's all I have. It's 5 minutes over. Anybody questions, concerns? Something doesn't make sense? All right.
No, I'm all good.
Get ready for the next Kahoot.